I come into my unit every morning wanting to solve problems. The idea is to come in with an open mind and say, today, there will be challenges. I'm curious to see how we're going to take on this series of challenges.
Yesterday, I asked the people in the recovery room if we ever had a code blue patient to go and take care of the patient. I'm going to ask the same question today because I don't see a lot of prospects if there's ever a code blue.
To be a good intensive care doctor, what it takes is the capacity to manage the impossible and to expect the unexpected. And dare I say, to be capable of not taking no for an answer.
Hello, we're expecting a convulsion in 3 to 4 minutes.
Around 50% of hospital admissions are due to emergencies. The role of emergency physicians in this section is largely about screening, stabilization, and good orientation. If you haven't done that, well, it's all going to go wrong.
This lady has been experiencing hyperglycemia for a few days. This morning she had convulsions, shaking all over, muscle spasms of all 4 limbs.
The initial orientation and treatment definitely make a big difference on the patient's progress. People can decline in 10 or 12 hours. They're your responsibility if you don't take the right path.
He needed a respirator, but he doesn't anymore. But he needs antibiotics. I think we're going to have him in all day. We've been treating premature babies for several decades now. Obviously, it's just that the barriers have been pushed back. When I was in training, we saved a baby born at 27 or 28 weeks. We were really happy, but now that's almost become the norm, in the sense that the opposite surprises us more when we haven't been able to save one of these babies. There's constant progress, like in many other fields of medicine. I have the phone.
Perfect.
I'll give it to you.
Okay.
That's good. Excellent.
Yes, this is Dr. Motard. How are you? Yes, I just wanted to tell you I'll be in surgery all day for a big operation. I won't be able to take any messages. I'll call you at the end of the day. Thanks, bye. There's a chance I can cure today's patient. That's why I offered him the surgery. He had a cancerous pelvic mass. The first time I saw it, I told him, we might be able to do surgery to save your leg, but we might be forced to remove not only your leg, but half of your pelvis. It was big news. Hi.
Hi.
How are you?
Fine.
Were you able to sleep yesterday?
As best I could.
Were you able to sleep a bit yesterday or not?
Yes. I slept.
Yes.
I slept.
Over 2 weeks, he had a full checkup, an MRI of his pelvis. When I saw it, suddenly he said, I know what you're going to say, because my pain has gotten so much worse. I can feel my tumor growing in my thigh. He had already made up his mind. He was really suffering. You should focus on removing your cancer. This action, despite what is going to change, will remove your cancer.
That's the point.
We try not to do hemipelvectomies like I'm going to do today. We're responsible for making the patient disabled for the rest of his life. However, it's the only surgery we can offer to cure him. Any surgery that didn't remove your thigh and pelvis wouldn't cure you. Is the surgery a guarantee? You know it isn't. Whatever happens, I'll be there the whole time. The whole time, the whole time, the whole time. If we find parts of the tumor that are very aggressive, the chances of curing this disease fall drastically. My hope for him is that 1, we remove the entire tumor, and 2, that when we do a full analysis of the tumor, we don't find a higher grade than grade 2. You know I'm waiting for the full analysis of the tumor. If it's grade 2, we'll have a glass of champagne. Sound good? We'll have a bottle if you want. It's amazing how when you explain to patients that you're doing this surgery, which will probably cure them, but it isn't guaranteed, the majority of patients who are about to undergo serious surgery like that are so calm.
Type of operation, critical stage.
It's going to be very long. He will lose between 1.7 and 3.5 pints of blood. Maybe more, but I've put bottles in reserve.
Great. Hope the surgery goes well.
Yes.
Are you unstable at all?
No, I've even...
Yeah, you're all right. Okay. My work is mostly in stem cell transplants. Anything involving stem cells, transplants, treating diseases with cells. I find it very stimulating. On the transplant floor, you mostly find patients with hematological cancer, whose only hope of a cure is a stem cell transplant. Good morning, I'm Dr. Lachance. I'm the hematologist on duty. How are you?
I'm fine.
You're fine? How's it going? Today's your second day of chemotherapy. How was it? Did you have any nausea? Did you have any vomiting? Do you feel a bit down or tired? When they're hospitalized, it's usually at a very difficult time in their treatment phase. I mean, they're going to have chemotherapy, often at strong doses, with the aim of completely destroying their hematologic and immune systems and replacing them with healthy hematologic and immune systems, which will allow them to respond to the illness themselves. So today, we're going to continue your chemotherapy. As you know, you'll have it for 7 days in total before the transplant. You have to be passionate for this job, as you're accompanying people who are going through extremely difficult times, and above all, who are juggling with the notion of life and death. Remind me, Mrs. Lavictoire, before your illness, before the lymphoma, were you in good health? Did you have any other health concerns?
No,
were you
no.
active?
Yes.
You walked?
Yeah, especially with my grandsons,
You have grandchildren.
they'd make me play soccer.
You play soccer. You're a grandma who plays soccer. That's extraordinary.
With my grandsons, they liked that.
I think my job is trying to cure or control illnesses, and also to give time. It's allowing a father to see his children grow up. It's allowing a mother to go to her daughter's graduation. It's the little things which seem simple in everyday life, but which means we'll have made people happy. Maybe that's what saving lives is. Have a nice day. See you tomorrow, Mrs. Lavictoire.
She's all wet. Okay. We'll lift your head up a bit. Hello, ma'am. My name is Audrey. We've come to Maisonneuve.
Hello.
Extreme
septic shock in a frail woman with dementia who appears to have been ill for 2, 3, 4 days. She's 84 years old. She's very ill. We'll see if she turns the corner or not. Her prognosis is more or less good. But choosing the right antibiotic, giving the right dose of antibiotics, rehydrating adequately, controlling her blood sugar, all that will give her the best chance of recovery. Past that, we can't control destiny. We can't control the forces of life and death. Can you hear me? Does she react when you jab her?
No.
How's he looking?
He was doing well last night. He gained weight.
A premature baby is any baby that is born somewhere between 23 and 36 weeks into pregnancy. But understandably, the most premature have the greatest needs. So that means, for example, here we take care of the most premature, compared to a less specialized unit where they only take care of babies that were born prematurely around 32 or 34 weeks.
We're calling from the delivery room because they have, in Le Grandeur, they want to transfer mom.
Yes, we have room.
Yes, transfer accepted. Thanks, bye.
Our work fundamentally is first of all to ensure these children survive, but obviously with the idea in the back of our heads that we want them to survive with the fewest after effects possible, or without any after effect at all.
Shall I tell the operating room to call us when they start the mom's epidural?
Yes. Yes.
Yes, that's right. When you start the epidural. Thank you.
In our field, there are emergencies, and there ends up being lots of improvising. Today began with a little more certainty because today we know there's a little baby who will be born prematurely at 28 weeks.
Dr. LaChapelle, we're going to surgery.
Ah, okay. Good. Let's go. I'll just text Dr. Begon, who had gone down. I have everything. My pen, my head. How do we know in advance? Because basically, a cesarean was scheduled because we already know this premature baby has been diagnosed with Down syndrome. In the last checkups, the baby's growth slowed down, as if the placenta wasn't working as well. Obviously here, it's a pregnancy that we can't let go on for longer, because he will end up dying in his mother's belly.
The latest estimated weight?
Between 1 and 2?
1 pound 14 ounces to 2 pounds 3 ounces.
I've been doing this for 25 years. Every time I find myself in an operating room or in a delivery room expecting a baby, you don't know what to expect. Even though you've seen a lot, each case is unique. You're always scared you'll have to stabilize the baby and you won't succeed.
Medicine is a science, but it's also an art. And to be happy practicing it, you have to have both aspects. I mean, to have science, but also to have art when it comes to patients. Good morning, Mathieu.
Hello.
How are you?
Okay.
Okay. How are we holding up? How did chemotherapy go?
Not so good.
No. Were you very nauseous?
Well, no. But I don't know. I feel worse compared to the other times.
Yes, because we're leaving feeling ill. The older I get, the more patients I treat that could be my children, for the most part. So it's clear that I have a maternal approach. It's my way of forming a relationship with the youngest ones. We'll take it one day at a time. Are you having visitors today?
I'm trying to rest.
Okay.
It isn't time to party. We'll party after.
So you're the one who tells people it isn't a good time to come see me. Are you okay with that?
Yeah, I'm tired.
Is this a time when you don't want to see anyone?
My girlfriend is coming anyway.
That's reassuring. That's reassuring. But you don't want to see lots of people. Okay. Can you let me examine you a little? From my point of view, it's important to build a rapport. For me, that's part of recovery.
Working every day with the sickest or most unstable patients isn't necessarily as terrible or as scary as you'd think. You have to put things in perspective. With my patients, there are no surprises. I know they're ill. I know they could hit me with a blow. Hello. I'm Dr. Marquis. I work with intensive care. Knowing that they're extremely ill, my radar is always on maximum. I come into the unit with my antenna deployed, and it gives me a head start. I often get a little more reaction time. Essentially, that's it. Yesterday, they brought you down because after the bronchoscopy, we were a bit worried about how you were going to breathe. Right now, it looks good. Okay. A patient who had blood cancer, which is treated by a bone marrow transplant. The treatment means that for a period of time, he doesn't have a functioning immune system. He has become vulnerable to infections. And when the immune system starts working, usually it gets a little overzealous and makes people sicker for a time. What we've seen here is a patient whose treatment is working. It's better to be in hematology upstairs. The isolation is better. Here, there's multi-drug resistant bacteria from intensive care. The last thing I want is for you to catch that. What I'm going to do today is send you back upstairs. Is that all right? Have a nice day. We are called to work in intensive care, but also anywhere in the hospital. There are emergency resuscitation rooms. There's going to be an extra emergency intensive care unit. I'm going down to the ER.
Suction here. Let's check.
Plastic bag?
Plastic bag, mini hat. This morning, there was an OB-GYN who performed a cesarean. Basically, she did all the work for the mom. If it's a cesarean, it's an operation. It uses anesthesia, too.
Take a deep breath. There we go. Great.
For us, our job really starts with the baby, in the sense that we're really specialized for the baby. We're not on the mom side at all. The secretions are suctioned.
Yes.
Put a CPAP on straight away.
Yes.
Before is more stressful than during, personally. Before is much more when we are anticipating what could happen. That's all the time.
Incision.
Bleeding when it's small like this is technically more difficult. Delivered. When the baby is born, the first minutes are critical. From the start, we have to be in control. That's going to influence everything that comes next. Hello, you. How many seconds are we up to? We're at 30 seconds. We can bring him gently, not too fast.
Should I bring him?
Yes, okay.
He can be put in the bag. There you go.
First, we stabilize their respiratory system. Of course, there are temperature issues too, as these babies can't get warm easily. Here, there you go. We don't have time to think much. If the baby isn't responding to all this, a moment will come when we'll have to quickly stop and think, where are we? What do we do? Do we continue? A baby born at 1.5 to 2 pounds can't survive on its own. If we're not there, it won't survive. This is a stage of life where we're saving lives. Okay? If it goes well, it goes well. But if not, that can be very intense. We're at 4 minutes. It's going well.
Saturation is good. Just raise the oxygen a little to 70.
He's okay.
That's good. His saturation is good.
Yes, that's good. That's very good. All right. Hi there. The operating room, more than the delivery room, is a bit of a hostile environment for premature babies. Why? Because operating rooms are cold, so it's a place where if a baby is kept for too long, there's a risk of hypothermia, despite everything we've put around him or her. All good?
I'm okay.
Yes. He's breathing by himself. His oxygen rate is very, very good. I'm sure that as soon as we stabilize his temperature, we can bring him up. But he's all right, okay? That's all we can do for now. Do you see him in his little bag? As soon as we're stable in the operating room, we don't hang around there because our workplace is the best environment for our little babies. The neonatal unit is where it happens. Clearly, we have to bring the baby as quickly as possible to the neonatal unit. That's where most of the care will be given over the next days and weeks. There you go. A little lovely baby born at 28 weeks, cesarean. It went really well.
Are you able to lift it over there so that I can start working on the pelvis?
The other side has been completely dissected. You can see the vessels.
Today, everything I do will be because I want to cure the patient. If I have to remove a structure that I hadn't planned to remove, rectum, bladder, spermatic cord, things that are very close to the tumor while I'm still in healer mode, I'll accept this as extra morbidity. Whereas if I take a palliative measure sometimes, I decide to change the game plan a little to reduce the consequences for the patient. When I'm thinking about saving someone, I get more aggressive. What's that? Not on the tumor side. Orthopedic surgery is very down to earth. It's very mechanical. Surgical oncology is very mechanical too, but there's a whole anatomical challenge. Every tumor is different, every patient is different. All anatomy is similar, but a tumor is never in the same place twice. A sarcoma can be anywhere, in any muscle, any shape, in any part of the anatomy, so you have to go everywhere. There's one going down here, but there's one going up. Or is it the same?
The same, I think.
The back of the artery was blocked. You knew the vein was going to be large. This was predicted by the MRI. We knew this would be the challenge. Really all the vascular control, because the tumor was very large and grew on all the vascular structures. No, we'll just start by making an incision. Then that will help us go deeper. Scissors? We had to start moving the bladder, remove one of the muscles, and in the end, I found it, and it went well. But the problem wasn't the artery, in fact. It was the vein underneath. Fixing a vein is like fixing a wet Kleenex. So as soon as you tear it a little, it starts bleeding. When you try to suture it, it starts to tear again.
Dr. Mortard, do you need Dr. Isley?
Sorry, put it on. After 8 hours of standing up to do surgery, you get tired. I need a break for 5-10 minutes, not long, just to get off my feet, have a glass of water. My partner, Mark Eastler, will come and replace me and vice versa. When he does hemibelvectomies, I often give him a hand for half an hour while he rests.
That should be okay. He's been breathing spontaneously.
Undercostal, intercostal.
Maybe we're due for some secretions. It's been a while.
Come on, dear. We're going to keep the bracelet, which is...
Yes, both bracelets.
Okay.
He hasn't been weighed either. Our neonatal staff are experts in caring for premature babies. Clearly, if there are techniques to do, for example, if we have to help a baby breathe, if we have to put him or her on a respirator, etc., we feel a bit more at home in the neonatal unit.
He's breathing quickly, but it's very shallow. I had him at 90. He's breathing fast and very shallow.
Let's weigh him.
Yes, I'm going to weigh him. 2 pounds,
2 pounds,
45
45 ounces. Life is definitely fragile, but at the same time, we always get the opposite example. The children we see are so fragile, but they have strength. Often, as the parents say, they're survivors, so there's strength despite the appearance of fragility. You're wondering what's going on, right?
We're in the emergency room.
What happened?
A man of around 70 was walking on the sidewalk and fell face first. Passersby called it in. Laceration here and also on the jaw.
Hello? I'm Dr. Gagnon. How are you? Not bad? Do you know where you are?
No.
At Maisonneuve Rosemont Hospital. His heart isn't beating very fast, like 28. That's most definitely the reason why he fell down. Do you remember coming here in the ambulance?
No.
No? Okay. He definitely has head trauma. He doesn't remember what happened at all. But apart from that, his pressure is good. He's stable. He's not hurting anywhere. He's responding to questions. We're just going to finish checking his fall. Brain scan, neck x-ray. Then once all that's clear, the cardiologist will see him and probably give him a pacemaker. So you've never had any heart problems?
No.
Heart?
No.
Never?
No.
Okay. Do you know if you take any blood thinning medication?
No, I don't.
Do you take any other medication?
No.
That's good.
Yes.
This is one of those patients with a single problem. A healthy man who doesn't take any medication or have any illness suddenly has a problem with his heart's electrical system. With science, we can replace the heart's electrical system with a pacemaker with 2 small electrodes. A cardiologist puts it in the blink of an eye, it's done. This will completely change this man's life. He doesn't have a real illness. He has a technical problem.
That's my heart.
Your heart's electrical system is slowing down slightly. Yes,
Oh, yeah?
we'll take care of it.
Thank you.
My pleasure.
Hello. Why is she in isolation?
Probably the flu.
Critical care doctors are called in to see almost all the patients who might take a turn for the worse or who take certain medications. There are certain medications we can't use outside of a unit like resuscitation or where we are now, intensive care. Right now, she's on these medications. I can't send her upstairs with these medications. When did she start coughing and feeling unwell?
About a week ago, she started. She told me she had some kind of flu.
Okay. Since she came here, has she been getting better or worse?
She's a little better, a tad better. But she's telling me that she's had big
shivers?
Huge shivers.
Her medical problem is essentially a respiratory problem. For now, I'm saying a respiratory problem, but it's not clear yet whether it's viral or bacterial or both. She could have the flu, a real flu, influenza. From there, it's damaging her lungs, so bacteria can take advantage. It's going to take us a few hours to determine exactly what's causing her breathing difficulties. But at the start, for us, the treatment remains the same: antibiotics and antivirals. We're going to give her fluid. All being well, we'll get rid of the intensive care medication. She'll be able to go upstairs. Okay, that's good.
Thank you, doctor.
See you in a moment.
Thank you.
Attention, code blue, Maisonneuve wing, 4th floor.
4th floor.
Where?
4. Code blue on 4, 4, 4. When a code blue is announced in a hospital, it's for a patient in a life-threatening situation. When this code is announced, we assume the patient is deceased. Most of the time, we have to try to resuscitate them, to restart their heart. Okay, what's happening? Do we have the chart?
Yes.
The longer it takes us to bring back circulation, the greater the risk of permanent damage. For us, it's a race against time. What rhythm do you have? The crowd during resuscitation is a necessary evil. A certain number of people are needed to be effective. Chest compressions are a serious workout. Every 2 or 3 minutes, you have to change the person doing the compressions. My mind is surprisingly very calm. It's the eye of the storm. Get the tube ready. This is when our training kicks in. You have to stay calm in these moments. There are things you have to do to keep the patient alive. Okay, take out the drain.
Inflate the balloon.
I have to find out why the patient is deceased. If I don't, either the resuscitation attempts won't work, or when we try to resuscitate them, they'll go into cardiac arrest again.
Pressure underway.
Okay, the airways are secure. The stomach is drained. We have a pressure point and saturation. For sure, the moment when there's a pulse and the patient starts breathing again, when there's pressure, is extremely satisfying. Maybe it's a primary respiratory arrest, something like that. Resuscitation is why I went into medicine. It's the ultimate way to save someone's life. Okay, thanks everyone. We're going to coordinate the transfer to intensive care. Yes, when the heart restarts, it's a huge relief. It brings you joy, for sure. Thanks. No, I know. Right. For us, resuscitation is a 4 out of 7. I mean, just because you've won the first game doesn't mean you've won the cup. There are more games that will lead us to victory. Victory isn't certain until you've won all the little victories. His heart is restarted. He's breathing. We're going to find out what happened exactly.
Can I touch him?
Yes, on the way, no problem. Would you like to come with me into the room? There's a window where the family can see the patient. It's not so much information they want, it's knowing he's all right. The only way to show them is by bringing them to the bedside. I have the patient's wife with me. She just wanted to see him. When I say he can't chat, think of it as an operation. Get closer, no problem. Okay, that's good. Are you okay? That's good. He's breathing on his own, okay? You have to understand that they're expressing worry, hope, faith. It's important to make them welcome, because this person is in distress. Their world has been turned upside down. Their loved one is dying or dead. They don't really know what's going on. The majority are not doctors. It's even worse if they are doctors, because they know how everything can go wrong. Take his hand, there you go. Talk to him a little.
Gerald, I'm here.
Gerald, open your eyes.
Gerald, I'm with you. Is he breathing?
Yes, this is just helping him. But he's the one breathing. His heart is beating on its own, okay? What's also important for me is to let them speak, to say things, to touch them. Because I don't know what will become of this person in an hour. I'll walk you to the front. We're just finishing preparing for him to be transferred, okay? As soon as he's in intensive care, you can see him again, okay?
Hey, it's been a long time since I saw you. How are you?
Better than last time.
Better? Well, you're in good shape. You're in much better shape than last time. In medicine, it's said we should be empathetic. That means being capable of getting emotionally involved, but keeping a healthy distance. I won't lie. When we treat patients for 5, 10, sometimes 15 years, they sometimes become part of our extended family. Emotional moments can arise. We become deeply attached to the patients we treat. After this treatment, we're hoping that you'll be in total remission again, and we can go on to the next step after that. Everything happens next will depend on the status of the disease. But the first step is no longer finding any of the disease in your marrow.
Is there a possibility that it's still there? That the treatment didn't work?
It's possible that it's always possible that the disease is still there. We'll find out together. She's a young woman who is a single mother. So she's very young, and she's raising her 6 or 7-year-old son alone. She's been treated for acute leukemia, but has unfortunately relapsed. It took me by surprise, because when I saw her at the time of her relapse, it was a regular checkup while she was healthy. She had just gone back to school, she was taking control of her life. I had to inform her. That was difficult, of course. How are the arrangements with your son?
Fine. My sister and mother are looking after him.
Good. So you've arranged it with your family. Do you talk to him?
Yes. I talk to him on Skype.
How's it going?
It's going well.
He isn't too bored?
Honestly, I think at first it was a bit hard for him to settle in. He threw tantrums.
That shows he's worried about you. That's why he's throwing tantrums.
I told him it was going to be okay. But I think day by day, it's going to be okay.
She's someone you want to save. I really want her to survive and to be able to raise her child.
Do we still have a pulse and pressure? All okay?
It's all great.
Once resuscitation has been successful, I should say the initial resuscitation, when the heart is restarted, the work begins. The easy part, it's regrettable to say, is restarting the heart. After, there's a long period of instability. The patient is really at risk of having another heart attack in the minutes and hours that follow, especially if we haven't found out why they had one to start with. He either has a vomit-filled lung, or his ribs are cracked and he has suffered a pulmonary contusion. Keep your curve, get in there. We're going to do a lung X-ray. When everyone else thinks it's over, the reality is that for us, it's just beginning. This is when I have to find out what happened to prevent it happening again. Do we have a contact? Okay. We won't extubate him straight away. Hello.
Mr. Chassé,
Mr. Chassé, squeeze my fingers.
I'm just gonna clean his face.
He's in the middle. We won't wake him right away. He'll be under observation all night. Now you have to live with the fact that resuscitation can lead to damage. We've spoken about brain damage, but with him, we've broken just about every rib he has. That's a challenge. It's hard to breathe. It hurts severely. Pain management is going to be a challenge. With a bit of luck tomorrow, he'll wake up and we'll be able to extubate him.
Then? You're back? Already? Okay, I'm on my way. I'll take your place, okay? The sacrum is at the base of the spine. Part of the sacrum must be removed along with the entire iliac wing of the hemipelvis. In the final moments of surgery, this can lead to heavy loss of blood because there are some blood vessels that pass below the tumor that I can't see until the hemipelvis is removed. Starting to bleed. We know there are large veins that we can't ligature. So at some point, the surgery has to end. Scissors? Give me another dish. Perfect. Now we have to take out the tumor. So we rush to finish the hemipelvectomy, removing the hemipelvis and then the leg. But this part must be done fast. It must be done well because otherwise it could be dangerous. One movement could put the patient's life in danger. Go, go, cut, cut.
At the start, the person who is involved in and going through the treatment is the patient. We suggest a therapeutic approach. And it's the patient who decides if they want to take this path or that. The power of doctors is often spoken about. There is no power. We have the ability to understand illnesses, to suggest therapeutic routes, to advise students on the different options and guide them in their therapeutic choices. But they're the ones who make the decisions. Are you feeling all right and ready for us to try something else?
Yes. Right now, yes.
Okay.
Unless you tell me it's really not worth it.
No, we're definitely going a little off the beaten track, but I think we have to change the way we're looking at your illness. Clearly, the illness isn't responding to conventional chemotherapy, so we have to think of something else. We're on the edge of a precipice somewhat. I mean, there's no standard option for him. We're looking internationally to see if there's a research program for which he'd be eligible. There are a few here, but they're often for family transplants. So we're searching.
Yeah.
We're with you in this. We're listening. It gets to me because he's young and he has relapsed. So there's a motivation to identify something, to think outside the box when it comes to his illness, to have a more innovative approach. These cases force us to think outside the box and want to push past limits. Okay, see you tomorrow. Good luck.
Thanks.
Bye, I'll keep you
Thanks.
posted.
Yeah.
Okay, on 3. 1, 2, 3.
On days like today, I don't feel so useful. In 3 months, when they wake up and see that life goes on, that's when I feel useful. But today, yeah, but I'm focusing on what I'm doing in the long term. In the long term, my goal is for him to be tumor-free, so he can live a fairly normal life as independently as possible. Yes, hello? Hey, hi, how are you? Hi, I tried to reach you. Listen, it went well. It was hard, but it went great. We've just got to do intensive care. We removed the tumor completely. All the danger has passed. It's over. I'm changing the patient's life dramatically, but this disability means he can continue living. That helps a bit with making decisions. It's a decision I completely take responsibility for. I'm convinced that if we hadn't done surgery to cure him now, even in 2 months, he would have asked me to do it just for the pain. I'm convinced. Yes, that's right. I don't think we even would have had a choice in the end. Even if the patient agrees to the surgery, he doesn't really understand what it means for daily life in the long term. This is a stage, but it's also about waking up in the months ahead. It's very hard. This is Dr. Moutard. The surgery went well. It's all done, okay? I've called your wife. You're in intensive care. You're going to sleep until tomorrow, okay? But it went really well. I experienced the joys of everyday life probably 1,000 times more than someone who doesn't deal with illness every day. I find that there are people who, in their daily lives, blow little things out of proportion. Sometimes I want to go to them and say, hey, you could have an osteosarcoma. I think that doctors who deal with cancer every day tend to put little everyday hiccups into perspective. Yeah, that comes with the job.
We keep the premature babies until, as often we tell parents, around the date when you're supposed to give birth, give or take 2 or 3 weeks. And in the first weeks, especially the first days, things can turn around at any time. It's too early to say that the baby has been saved and we can sleep easy. But we're off to a good start, that's for sure. Mrs. Antoine? You thought about hiding. How are you?
I'm okay. This is my baby.
Feeling better? Who's that? It's your daughter on the other side. Oh, that's a good idea. On this monitor here, if you look at the images, there are wires everywhere. That's to monitor his heart, his breathing, his oxygen levels, everything. Things are going really well on that front right now. He's really behaving how we would expect from a baby born at 28 weeks. Above all, he's energetic, in the sense that as much as when he came out, as now, if we disturb him, he doesn't like it, and he tells us. He tells us. Basically, this is the ideal situation for a baby born at 28 weeks, all right? When will you be able to come and see him?
Tomorrow.
Tomorrow? Oh, how lucky that you have... Thank God for technology. That's great. We're not giving up. See you.
Thanks a lot.
It's true that I helped save a life, but at the same time, my first instinct when I see this little guy in front of me is that I'm proud of him, because he beat the odds and our apprehensions. But we're proud of him. I'm not proud of myself. I'm proud of him. Sometimes when I hear a mom tell her child of 5 or 6 or 7, you know, he was the one who saved your life. Okay, that feels good. But you mustn't get too big-headed. It's what we've chosen to do, and we do it. But I mean, everyone who looks after these children, the nurses, the therapists, they all save lives as well, because everyone has a little part to play.
You can go 2 at a time. Then you can take turns. The nurses will give you the details. Come on, let's go see him. A successful situation, a successful resuscitation, usually gives me joy and satisfaction, but not always. Sometimes I think, we were just lucky. There's no merit in that. Then other times, there are situations that are catastrophic and end badly. But I'm content with what happened, because I think that in that situation, we couldn't have done anything more. A life can hang on very little. Sometimes you can save a life just through prevention, but that doesn't mean a life wasn't saved. The small gesture of administering good treatment or making a small change that will make a difference down the line is just as important as a dramatic code blue with resuscitation and all the equipment.
If you want to broaden what it means to save a life, look at the teenager you convinced to quit smoking. In a way, you saved his life. In a certain sense, life is extremely fragile. But in another way, human beings are immensely resilient. It's incredible to see people who are really very sick get through it. It's almost unbelievable. Then something mundane happens, like you fall down a couple of stairs, you hit your head, have a massive hemorrhage, and die. There's a kind of nonsense in all this resilience and fragility that's very beautiful. It makes you put your role as a doctor into perspective. You don't have absolute power because you aren't a god. You do what science has learned to do. Beyond that, life is stronger than anything else.